Hi everyone, welcome to my live session. I'm Dr. Raki Yadav, consultant pediatrician, and today's topic is COVID-19, the long-term effects, or sometimes known as the long COVID or COVID long haulers. There are a couple of terminologies to it, and I have with me my guest speaker, Associate Professor Dr. Anwar Suhaimi. And Dr. Anwar is actually a consultant rehabilitation physician. He's trained in various countries, Malaysia, Australia, as well as in Turkey. And he's currently leading the COVID-19 rehab services provision in University Malay Medical Center. I'll just wait for him to join us in. Let me just add him in. Hang on just a minute, yeah. Sorry, just give me a minute. Let me just add live. Okay.
Dr. Raki.
Hi, Prof.
Hello. Now let's not scare everybody here.
Okay,
Raki and I go a long way.
Long way back. But we're still young, very much young at heart.
Oh, yeah.
Thank you so much. I'll just call you Anwar for the whole conversation because I'm just not used to the prof thing yet. But congratulations on that. Well done. So happy for you. So I was just telling everybody that we're delighted to speak to Professor Dr. Anwar Suhaimi, who is a consultant rehabilitation specialist, and you're trained in various places, Malaysia, Turkey, Australia, and you are also leading the COVID-19 rehabilitation services in University Malaya Medical Center. So excellent background. Thank you so much for joining us for the live sessions today. Would you like to tell us a little bit about yourself?
I think you spilled everything already. So well, keeping in tonight's context. So yes, as Dr. Raki mentioned earlier on, we are working in a team. So I wouldn't say I'm the only person doing everything, but definitely rehabilitation is gathering its strength. We are coordinating our services because I think one of the questions, and probably we would like to touch about this later, are we ready for the aftermath? So literally, we are talking about we are talking about moving on with the COVID, but I think after tonight, we have to rethink about how soon can we leave this COVID or it leaves us. So the sooner we get our act together in terms of not just the acute medical service, which I think, TKM and all doing a fantastic job, despite whatever we're seeing around us. But now it's time to look into what's coming next. And preparation is our best deal if we were to actually overcome long COVID. Oh, okay. You can't hear me. I think I'm just going to take this off. And and is it any better? No? Not good? Okay, hang on. Hang on.
Sorry, couldn't hear you very clearly just now. So I was just wondering if it was the speaker or...
Does this do the trick?
Yeah, that's much better.
Better?
Yeah, excellent. Yeah, it's much better. Thank you so much. Thanks. There's so much that you're going to tell us about in the next couple of minutes, and I don't want anybody to miss that out. I'm going to dive straight into it. So what are the long-term effects of COVID-19? What do we know?
Sorry, Raki, I can't quite hear you. So just hang on. Let me just fix that.
Is that better? Can you hear me now? Oops.
Technology, it just happens.
Oh, okay, much better.
You can hear me, I can't hear you though. So anyways, I'm just gonna have to come very close. All right, sorry, what did I miss?
All right, no, so I was just saying, I'll get straight right into it. What are the long-term effects of COVID-19? You want to just tell us what we know so far about the long-term effects, even though we've only known COVID for the past almost 2 years, but we do know there are some long-term effects after getting infected. We have patients that have been infected as early as January, February, March last year, and that has already gone into more than a year. So what do you know about long-term effects of COVID-19?
Actually, not much, but here's the but. We have learned from SARS. And SARS has taught us a lot because the closest we have to COVID is SARS in terms of the respiratory virus and the organ effects. So late 2020, the rehab fraternity already begin to talk about this is going to be like SARS. Are we ready? Ready for what? So they're talking about this post-acute COVID. So this is what it is. So just to clear the air, it doesn't mean that the person is infective. COVID is after you fulfill certain criteria, the patients de-isolated. They are no more potentially able to spread the virus. Yes, they can have the virus within themselves, but they can't spread it to others. But the consequence of being in bed, lying down for very long because the person's ill, it sort of breaks the body down. So the body, when I say the body, you're not just looking at the physical body. Yes, so musculoskeletal deconditioning, as the word implies, it means there is weakness, there is poor endurance or poor stamina. So that can come from either direct lung injury or from lying down too long, and you just become, basically the body is a machine, it's a temple, if you want to call it. So basically it's just in ruins. And now, scary bit, Raki, we are noticing that there are patients after COVID who begins to complain of memory loss. So it's nothing to do, first we thought, okay, you know what, because you're intubated, you might have, we are doctors, so we know things happen when you get intubated and stuff, but it's got nothing to do with that. So why I said yes and no, we know something, but we are still learning about COVID. Especially the long COVID, is because what we know is what we inferred. And certain things are rather similar, but we are noticing a lot of things are actually novel. And we are learning this. And when I say we, it's not just Malaysia, all over the world. So that's why, when people talked about, can we prevent long COVID? The answer is we are still struggling with the acute numbers. What we have is the first year, last year, the survivors of last year, we managed to see how they progress. The data that came out from Ministry of Health, Sungai Buloh in particular, was actually of 12 weeks, so 3 months. And at 3 months, we already have a good set of data, about 1,000 plus people who we follow up, and we can see the trend. And I must say, it's somewhat similar to what we expected of SARS, but we are seeing new novel stuff, so like the memory fog. So that's new. Involvement of the heart, that's potentially it. So we don't have much data on that, but we are collecting numbers as we speak. So I guess the full picture probably will come later towards this year. Malaysia has survived 3, now we're going for number 4, wave number 4. So we'll see how things go. So yeah.
Right, so it basically can affect any organ because of the way COVID virus affects our body. It can affect any part. So like you said, memory, some of them say brain fog, they can't really remember, they're not sure what's going on, they're forgetting. It's not as simple as you forget where you kept your car keys. It's more than that. It's like, I can't remember where I am. What was I saying? What are you saying? I have a few patients who are like, they're just completely off. And there was a study that I saw yesterday that also said that there is propensity for these people to develop early dementia or early Alzheimer's. Yeah. So that's even scarier, so the fact that it can affect multiple organs, and it can be quite some time. Which brings me to my next question. When are these people considered to be having long COVID effects? Or how do you diagnose, like, okay, you're no more in the acute phase and this is long-term effects. So when do you diagnose them?
Right. So we generally assume that this is directly from acute COVID infection if it's less than 12 weeks. So let's say you develop shortness of breath or you're coughing persistently. If it's less than 12 weeks, we will say, okay, this is actually relating to the lung injury that you had because of COVID, or the patient has become declined. This is when you sort of think, hey, could this be long COVID? Because if you think about it, Raki, all this, scarring over the lungs and all will be done by 6 to 12 weeks. So most centers that follow up, like for example in PPM, when we follow up, we are happy to discharge patients after 12 weeks. Okay, but if they have got persistent problems and we have to keep following up, that is most likely long COVID. Yeah. So 12 weeks and beyond, I would say.
All right. So if anybody has symptoms more than 3 months, so 12 weeks will be more than 3 months, then you would think that this is no more an acute COVID reaction. It is more of some sort of long-term effects. And as far as I know, we're not sure how long these effects can actually last, because whether they last for 6 months, 9 months, your guess is as good as mine. And we're still, I think there's a lot of trials and a lot of research that's going into this because of the huge numbers that we're seeing. So it's not just about the the death rate, the morbidity rate, how many of them are in hospital. It's those who survive out of the hospital, and those eventually become your patients. So what about treatment? How do we know what to treat, how to treat, and is there any specific treatment for this group of people?
So if you think about it, long COVID can come either as a direct result from the acute infection itself. So like I said, in ICU, you were laying prone for many, many days. They had to use certain drugs. And then after that, we had to use massive amount of steroids just to make sure the lungs are not scarred. So that can directly, when I say can, because we are trying to establish the causal effect, and we have not been able to do yet. But like I said, learning from SARS, and that was what we saw then. Now moving forward, you're looking at new complications, like the brain and the heart, because we are still learning and we are following up those who have survived the first and second wave, and we are looking at how they responded. So back to your question, can we do anything to treat? Definitely. Of course, I would say prevention is better than cure, and detecting who is at risk would be of paramount importance. So I would say those who have been in ICU or category 5 COVID are the ones with highest risk. The patients or individuals with previous the more medical comorbidities you have, diabetes and heart problem and whatnot, the higher of the chances, either direct from the disease or because these patients are usually very ill because of COVID, and then they become very ill because they also have other medical issues. So they spend a longer time in the intensive care or being, bedbound because of the effects of acute COVID. And then we are looking at people who, for example, the brain fog. We've noticed an association between anosmia, the loss of smell, and the occurrence of brain fog. So it might be indicating that the virus is actually migrating or moving towards the brain. Why I say may? It's in observation. We are still looking at how strong is that relationship, and of course, seeing the virus actually moving up is one thing. So, can we prevent this? I think the first thing is, from the acute side, is to be vigilant, to look into patients who have identified with a higher risk, and starting rehab. So a lot of people ask me, when can you do rehab? After leaving hospital, I said, no, in the war zone called ICU, you can basically start rehab. So it's the matter of provision, and we're talking about administrative and that sort of thing. Provision of rehab in the acute setup, which I think most major hospitals have got the manpower to do it. It's just whether you are so drained by acute staff and that sort of thing. You look at the number of patients waiting to get admitted. People the manpower gets drained to manage all these things rather than rehabbing. Then we actually identify those who are at higher risk. So the worse the category, most likely you will end up with complications. Yes, these are the ones that needs early rehab, inpatient. Now, WHO, World Health Organization, actually did, you can Google this up. They actually gave a discharge home pamphlet that patients can bring back. So unfortunately, we don't have it in Malay yet, and we are trying to actually translate that and contribute to WHO. That WHO leaflet actually gives a very simple, basic, not just checklist for the patients or their loved ones to actually screen and be on the lookout, because sometimes if let's say you are a COVID survivor, you might not notice that you are actually a bit more lethargic or fatigued, but others surround you, like your employers might notice that. So it's like helping each other out. We should be looking for each other. And then, because some of these things involves function, and things like weakness, endurance, is very amenable to exercise. But of course, you're able to tell you, okay, let's exercise. You don't have any head and tail of how and what to do, and that's what the WHO handout aims to sort of give an information. But the bottom line is, Raki, I want to say that if you find that things are a little bit out of control, please reach out. People, like most patients that I admit for inpatient rehab, they can't wait to go back. They'll be on oxygen, they can't even take 2 steps, but they're like, doctor, I just want to go back. I'm done with hospital, which I can absolutely understand. But I think it's more dangerous that you actually go back and literally trip over your face because you are so out of breath. And simple things like just a few days in rehab. My experience, ICU, straight out of ICU with us for 2 weeks, going back home, walking indoors. And when I see them as outpatient, the oxygen, they left it behind. So I'm saying that what we can do is essentially the rehab bit, and you need to identify if your loved ones or COVID survivors actually have these signs, and get them into medical help as soon as possible.
Okay, so the ones that are admitted, so now you're saying the only way to prevent is by finding out who are the ones that are high risk of getting long COVID. So you get a referral from the specialist in ICU that, okay, these guys are, so that's how you start off your treatment inpatient in ICU. And do you see referrals from outside, like from clinics and all that? What
Yes,
about
we
like a
do.
GP sending you or something? So you do
We
see
do.
that case?
Yeah. So
Okay.
as of for the time being, we have got a outpatient COVID follow-up, which clinic, which I think most major hospitals. I know Sungai Buloh definitely has it because that's the epicenter of COVID. PPUM also has it. We identify patients who presents with symptoms like dyspnea, shortness of breath, fatigue, extreme fatigue, anxiety, and depression. A big bulk of the younger ones are actually having, it's multifactorial. Okay, some of them lost their job. It was a grief reaction, but nonetheless, some of them it was grief. It was bad enough that it's actually affecting their daily function. So we picked up all these things, and if it's not amenable to rehab, we initiate the early referral. I think, Raki, what you're trying to get at is there a diagnostic criteria? Well, this is a clinical diagnosis. You just have to look at. There's no specific blood markers or stuff like that. Even if you have, let's say, a patient has got abnormal chest X-ray, it does not show correlation. It's actually what the patient performs or the individual is able to perform or unable to perform. That sort of says that you actually have the sequelae from COVID.
So it's not as simple as like, when you diagnose asthma, you have the GINA guidelines, you have, an ARI guide. You have so many guidelines to say, okay, you have top, you have asthma. But it's not as clear cut that, in the sense that it could be so vague. It's a very gray area, and it could be something from mental health to brain fog. It could be so many things, and a vast majority of organs that are affected. So that's really scary, actually. So is there any way that we can reduce the possibility of getting long-term side effects? Like, we know, okay, we got to pick them up early, we got to start treatment early, but is there any way that we can reduce chances of us getting it?
I think vigilance. It's a tricky question because the name long COVID means it's post-acute. So and this is why we want to sort of catch it before it happens, and that's why we are trying to learn who is at risk so that we can prioritize treatment, rehab. And I think right now there are a lot of guidelines going out there about how long, for example, prednisolone, is a big debate on how long you should give the prednisolone, and you have got the different chest physicians with different ideas. I would say because we are learning, and we have to, it's a very steep learning curve. We thought, oh, this is just another SARS. No, it's definitely not. This is unprecedented. So likewise, for long COVID. So what we've learned so far is what we've learned from SARS. However, the key thing is because the body breaks down if you let it rest for too long. So the importance then lies in trying to ambulate or mobilize the patient as soon as possible. So go all out in terms of managing all the lung injuries, getting them well as soon as possible. So, the use of steroids and prone ventilation and neuromuscular blockade. But having said that, it's not as easy as, okay, you're done with 7 days on neuromuscular blockade, I'm just going to wake you up. No, it's not that. It's always based on clinical. So when you have this sort of patient, do reach out to your rehab colleagues. This is mainly for the medical personnel. Do reach out for your rehab colleagues, because there's actually a lot of things that we can do. Okay, maybe, some of the equipment and technology is expensive, but it doesn't mean we cannot be creative, and doesn't mean we can't do anything at all if we don't have it. It's not all or none. But what I would say is the vigilance, and this is why I'm coming up, I took out your invitation, Raki, because I want people to know that it doesn't end once the patient leaves the hospital. Definitely it does not end there. We all have to be vigilant. We all have to look out for each other. And then it's good to sort of think in a way that the cure is not another pill to pop. It's basically getting out there, getting an exercise, getting up on your feet. And, in terms of, I say, like brain fog, it's cognitive rehab. So things like, it doesn't involve pills, more pills, so stuff like that. So it's actually, in terms of side effects, it's probably not as bad as, having more and more steroids, for example. So yeah, I think the only thing I can say right now is be vigilant, because we are still trying to grapple with the effect, and we don't know how long it's gonna affect the patient.
With regards to the brain fog, I mean, I saw this. It's in a zombie movie, you know, like the zombie apocalypse movie, and it was like, you know, they said the first stage is you lose your mind, you become forgetful. You know? So this is just to everybody out there. This is not medical, so I'm just asking on my own. So they said that, you know, you try to recollect numbers. So you write down a number, like, you know, a 5-digit number. And then you close it for like 5 seconds. You close your eyes for 5 seconds, and you try to recollect that number. Or a phone number. A lot of us now have smartphones. We don't even remember our home house numbers, you know.
Yep.
So is that some way that we can do all crossword puzzles or doing Sudoku? Are these some methods that we can actually use to like sort of stimulate the brain to, you know, chug back again and all? Do you think these methods might work in some ways?
Well, definitely number one, if let's say you're interested in screening and finding out whether you're in problem, you guys can Google up My 480. My stands for Malaysian 480. It's just basically 4 questions. It's really simple. Your name, as in the patient's name, date of birth, what year are we in, and then count backwards from 20 to 1. It's very simple. So you're not allowed to fail. If you fail in any one of this, then that's problem. Okay, so now we move on to treatment. Okay, so treatment or rather prevention that we can do at home, for me, is to keep our minds engaged. A lot of times we are trying to find out whether this is actual viral impact on the brain or the effect of being locked up in a ICU bed or in an isolation room for days or weeks, and this is called cognitive deconditioning. Okay, so even us, you know, when we get off a plane, that's been many years, right, since we got off a plane. You know, you get off a plane on a foreign land. You get off a plane on a foreign land, and then you'll be thinking, what time on, you know, what time of the day or what day of the week. So that is the sort of deconditioning that you can get after being locked up. Something like jet lag, but you know, it's not very obvious. I mean, Raki, if it's actually very obvious cognitive deficit, the person will behave like a demented patient. Yeah, you don't you know, was doing something halfway and sort of got sidetracked and then unable to recall what was I doing. So that is quite severe. And then again, you got to make sure that it's not some pre-existing medical condition. And it's actually from COVID. Okay.
And I was just gonna, bring back to the last part of my question, which would be who will be taking care of this group of people? Like you mentioned, for the healthcare guys out there who are listening, make sure you know that there is such a thing as rehabilitation services. There is rehabilitation Prof. Anwar. So there is rehabilitation services available in most tertiary hospitals. In fact, I think all tertiary hospitals will have, certain district hospitals will have, and it's a completely different healthcare sector on its own, and it is a wide variety. We all think that rehab you're just taking care of stroke patients, post heart attack, that's about it. But actually, you guys do a lot more than that. But who else are involved in taking care of these long COVID patients? Like, are you the manager and you're coordinating a couple of people, or are you like the main team and then you have sub-committee members, that are in there that manage it? So how does it work in long COVID patients? Who manages them?
Okay, so initially, Raki, we as in myself and my fellow intensivist colleagues were the ones who sort of started looking at RSV, because like I said, these are the ones who either end up with PICS, post-ICU care syndrome, or from long COVID. So at that time, this is talking about almost a year ago, we were not sure whether this is COVID or PICS. Either way, they present almost the same and they have got functional price to pay. So fast forward, of course, the bandwagon was joined by ID, infectious disease, you've got chest, you've got gastroenterologists, you have got the occasional ENT, and you've got the cardiologist. And we've got geriatricians on board who are looking more for, and of course, pediatrics, of course, on the pediatric side, definitely. But I think in terms of, everyone is sort of just looking at chest, is looking at respiratory, and, gastro is just looking at liver, transaminitis. It's good in a way, because when we are sitting in one clinic, I can just reach out to them and say, hey, we've got this patient who's just nicely desaturating at the 75%, in front of our faces. What do we do? So, and this is good, but it is the rehabilitation that actually looks at these patients, because they have a potential of permanent impairments. I don't want to use the word disability, because disability sounds very gray, and impairments meaning that they can have a permanent let's say short-term memory loss, or they can have a permanent shortness of breath after they cross a few meters. So the thing is, this is definitely not belonging to a organ anymore. This is going to be a whole person, you know, holistic, functional point of view. So if I were to say that rehabilitation will sort of tie in the few systems together and work on towards gaining as much function as possible. So I would say that we are there not looking at one particular system, but looking at as a whole and coordinating between, because if you think about it, after 12, let's say 12 weeks, you know, there's going to be lung fibrosis. Okay, chest physician say, we've given you enough steroid, you're going to get lung fibrosis, move on with life. What's next? Rehab. So, okay, so you've got limitation, you know, you've got dyspnea after walking after 100 meters. So what can we do? Pulmonary rehab. There, I mean, if you can't boost the lungs, we can boost the skeletal muscles, we can boost the oxygen carrying capacity, we can boost the mitochondria activity. So there's all these things occurs in rehab. But people say, oh, rehab is just physio. No, it goes beyond.
Yes, exactly.
It goes beyond.
Oh, you got a swimming pool as well, you know, wow.
Well, no, I'm not. Sorry, carry on.
Yeah, no, so I was saying, you know, when you look at rehab, they think it's, you know, it's like it's just physio. You're gonna do some exercise, you're gonna jump in the swimming pool, do some exercises in the pool, and that's but it's a lot more than that. It's a holistic, like, you know, it's a full version of it. Yeah.
So if you look, Rati, if you look at the WHO handout, you notice that they focus on 5 things: respiratory, aerobic endurance or stamina, swallowing, and speech. So don't forget, we've got the speech and language pathologists also in the group. So the patients, COVID survivors can have problems, especially those who are intubated, but even those who are not intubated because they lost so much of muscle power in terms of their speech and swallowing and because of the cough. They looked into cognitive, and they look into anxiety and depression, mood. So, you know, these are things that if you just look at a person, how can you tell they're anxious and depressed? But definitely in terms of function, they will be much affected. So we got to do the teasing out. Is this because of cognitive, or is this because the patient is just anxious and depressed, or fatigue? You know, the younger age group that I'm seeing are all complaining of fatigue, and you know, dah lah tak boleh kerja, and then fatigue, and then, you know, they get short of breath when they're just trying to just go to the toilet and managing themselves. So it is very depressing, you know, and let's not talk about suicide rates and whatnot.
I mean, so it's you know, one problem is just going to lead to another and another, and I think it's just going to make you even more, your whole confidence in, and you know, your whole lookout on life and everything is just going to be, you know, depressed in a lot of ways. And it spirals downwards, you know, because like suddenly you could function, you could run a marathon, and now suddenly you're out of breath when you take 10 steps, you know, or you feel so tired. Chronic fatigue is something that we do see in some of the long COVIDs. So that's something that's even more, I mean, it's sad to see that someone who was completely healthy before this, you get infected and then you're out in hospital for a month or so, and then when you recover, you're still not recovered. And then you get thrown with the fact that this could be permanent, you know? So it's absolutely, so a lot of people don't realize that.
The permanency can change with rehab. So that's probably the glimmer of hope that I'm trying to put in, you know. I mean, can I promise 100%? No, but I can tell you we're going to try. And I want the survivors to try, because that's probably the only way that we can sort of overcome this over the long run.
All right. Is there any way they can reach out? Like if a patient is thinking, I may have long COVID, I may have some symptoms that I'm not very happy about, how do they reach out? I mean, can they can't obviously get a, you know, how do they reach out to rehab services in hospitals?
So if you look at the CPG, so there is actually a CPG, a Malaysian CPG on COVID, and there's a chapter on long COVID which was written by our colleagues from Sungai Buloh, the rehab physicians, and from Serdang, and from Queen Elizabeth Sabah. So basically 2 main teams, the rehab and family medicine specialists. So I guess reach out to centers that are actually managing COVID, and these are usually tertiary hospitals, the tertiary government hospitals in every state. They are the designated COVID hospitals, or your family doctor, you know, explaining that you might be concerned about long COVID. And I must say that maybe not a lot of people are comfortable and they will initiate that referral. In terms of like Sungai Buloh and PPM, I think to be very frank, we are actually overwhelmed with our own numbers, but it doesn't mean that we don't want to see these patients. But by all means, do try and reach out to any hospital that has got rehab services. I even know of private centers, private rehab centers that actually offer long COVID rehab.
Okay, we have a question from, actually that's Prof. Amir. He's our immunologist.
Hi,
What's
Prof.
the prevalence of long COVID in Malaysia? So
Okay.
do you have a current number?
So this is the numbers coming up from Sungai Buloh. If I'm not mistaken, you can actually look in the CPG. We're looking at 6% of the survivors. These are the ones who came with complications after 12 weeks. We don't know how the survival curve is going after 12 weeks. So that means whether they sort of go away or are they persistent. So yeah, we're looking at, I'm not mistaken, 6 to 12% of the survivors.
All right, so 6 to 12% of the current survivors, because we have, I think we've already touched 800,000 in our country of cases.
Looking like
thanks
it.
to today's 8,000. People look at 8, I think it's like good luck. I'm like, no, I just want it to be at a single digit, not four digits. But
Soon,
yeah,
hopefully.
so Prof, I think it's 6 to 12%, and that's an increasing number, and that's actually quite huge if you're going to look at it. And like you said, pediatrics is something that you also see long-term effects. And imagine if you're a child that is like, I had a couple of newborns that came and saw me 2 weeks back, and they were positive for COVID because it was brought home by their parents. And so now you're looking at a newborn that's just 2 weeks old. Imagine the long-term effects it is to a child that long. I mean, a lot of people say children are asymptomatic and mild symptoms, but yeah, it's not just the active period that we're talking about. It's the long-term effects that we're looking at.
It's a matter of detection.
Yeah.
It's a matter of detection. I guess, if the child can talk and tell you everything that's going wrong with him or her, you probably get more. So this is what we're trying to say, detection. And that number 6 to 12 might change if more people step up. The reason why I'm saying so is because we are now, like I say, I initially started with following up the ICUs. We have a very sad number of ICU patients coming back. I don't know whether they passed away or what happened to them. I mean, we're trying to call them back, but those who are giving clinic appointments, they hardly turn up. So I don't know, is it because they're too ill, they're stuck on an oxygen, they can't come, and so the numbers could be more. Yeah, it's just that we're not picking up. Maybe if we do things like tele medicine, we call them at home and find out, maybe you get more. We don't know.
It's just the resources. I think everybody is just the burden in Klang Valley is absolutely crazy at the moment, and it's just difficult to manage a huge number in just one or two tertiary centers in the state. So, do you have any last messages for everybody out there?
I'll say two things. Number one, for survivors of COVID, don't give up. I mean, I know this sounds bleak and everything, but I want you to be vigilant. I want you to be resourceful. I want you to reach out if you need whatever reason you need to reach out. May it be physical, psychological, social. We need to reach out, and to everyone else, the family members, the loved ones, the employers, people around. Please do keep a lookout for long COVID. Okay, so you can just Google it up, and I know literally it's everything, but if you think something's amiss with your loved ones, with your employees, with your friend, do ask them to actually have themselves checked. Is there a support group, Prof? I think right now, Prof, we are so busy trying to save people, make sure they can breathe and that sort of thing, and I think if we want to start a support group, that will be huge. But I think to just answer you at the moment, the support will come through the rehab group. So because when they go for rehab, they go in together with the therapists and all. So that is a form of social outlet, if you can say in that way. I think there's another question there, Raki, if you don't mind reading out.
Yeah, I know. Just to touch on the support group, there are a lot of overseas support groups. So because America had a lot of cases as well, UK also had a lot of cases, and they are very fast with creating support groups here, there, and everywhere. So what you have to do is probably go on Facebook and look up long haulers, long COVID support group, or Instagram long COVIDs, and you'll probably come across a lot of people who are in the same boat as you, and you might be able to learn from personal experiences and maybe some of the things that you can actually figure out from others. And we have a question from Dr. Cheng. Long COVID can cause significant reduction in lung heart function due to damage or fibrosis. Can elite athletes ever get back to their previous performance levels? Oh, tough one.
Wen Long knows the answer. So he's our sports physician, by the way, Raki, if you need to know who Dr. Cheng is. Very good one. So it's a trick question. Okay, Wen Long, the answer is number one, we need to get hold of those who actually have got more the worst damage. I mean, you know, I've got a gentleman who I admitted last week from ICU. He lost 75% of his lungs, one from fibrosis, and he got PE. Must remember, yeah, stroke and PE is very high rates in COVID, okay, because they get thromboembolism. Yeah, so he lost 75% of his lungs. You know what he spent? He does the whole day. He just curl up in his bed and just sleep. And I was looking at him. I said, if he does this any longer, he's going to get depressed. So the thing is, right now, when you talk about performance, it's not just lungs. Performance is a whole bundle of things. You know, it's everything, including motivation. Okay, let alone your potential in terms of cardiorespiratory, musculoskeletal strength. And the answer is, if you catch these people early, you can overcome it early. If you catch them late, it's okay, but you're just going to take double the time. So deconditioning, the rule of thumb, Raki, if let's say the patient is just lying down in bed for 2 weeks, you need 4 weeks to get them back on their feet. 4 weeks.
Wow.
Okay, so that is just an arbitrary number. It's not particular to COVID. This is what we know so far, you know. So the longer the person rests, the longer they're just bed bound, the longer it takes. You know, even for simple things like after lying down for so long, you stood up and then the BP goes down, right? It's not going to correct.
Yes.
If let's say it's just a short period, yeah, you just need half a day for the BP to get back up. But if you've been lying down for the last 2 weeks, most of our COVID patients are lying prone for the last 2 weeks. So you're going to take a month to actually recuperate in terms of not just doing anything physical. It's just getting your BP and your heart rate up just for doing. So I think the long answer is, when you talk about elite athletes, these are people who have got a higher level of performance demands on them. So I think it's possible. Number one, catch them early. Number two, hit hard on them and have some sort of surveillance. So at the moment, going back to Raki's earlier question about parameters, we don't have one single parameter that is corresponding to an outcome. We are collecting data. So as we speak, when we see patients, we are trying to see, okay, how about your psychological outlook? Does it influence anything? How's your 6-minute walk test? Does it influence anything? You know, how bad is your lung? There is no, but at the time there's no scoring. So the way that we're going to approach this is going to be clinical. Okay, and this is where we still stand very relevant. Otherwise, a phone app can replace us anytime. It needs your clinical decision to think, when you're trying to enhance someone's performance, what are the components needed? Let's say you want to go back, you want a patient to return back to work, okay? Your return to work and my return to work cannot be the same. Someone's a manual laborer as compared to me who just sits at my desk cannot be the same. So performance is very individualistic, and we need to see what components are affected and what can we optimize. So the rule is, the faster the better. But if let's say you catch them late, still don't give up. There's still something that we can do. Hope that answers you, Cheng. Thank you so much for the question.
Wow, excellent. And we have Prof. Amir, who just commented that he's in touch with many overseas groups and patients. Prof, if you have any, maybe any, if you want to just DM Prof. Anwar and see, and maybe y'all can work out and see if you can start a support system in Malaysia. I think there'll be definitely a lot of group of people who would rather not go to the hospital with the current situation, and they rather you know, have supports. At least they've got something rather than nothing, and it will be excellent to have a basic support system, or just someone to, you know, it's basically you need someone to hold your hand, you know, rather than, you know, go to the hospital, you know, get scared and someone's got COVID, somebody's gonna cough on me again, I'm going to get a second COVID, you know. So sometimes
I think
a support
a reliable source of information. You know, nowadays if you just Google long COVID, you get Tom, Dick, and Harry saying, you know, X, Y, and Z about a lot of things.
Yeah, excellent. So maybe that's something that we can look forward to in the future of rehabilitation for COVID-19 long patients. And with that, I think we've come to the end of my questions. Is there anything else that you'd like to say, Prof. Anwar?
I thank you very much. I think, Raki, you're doing an excellent work, you know, getting everybody, you know, in the same boat and working towards. And this should be the spirit. It's so sad to see patients going into the hospital alone, spending time in isolation, and, you know, don't know what's the outcome. We are medical, we are non-medical. If you're medical, we need to be educating people about and basically raising awareness, just like what you're doing right now, you know, that it doesn't just end there, and, you know, there's still hope Of course, it sounds grey and
Yeah.
murky at the moment, but the faster we come together and we pull resources, like, you know, you're talking about support group and whatnot, the more we can actually not just help, but disseminate the help. You know, for me, the numbers, the statistics that we are gathering is useless if you can't do anything about it. You know, you can't get
Yes.
the help to where it's needed most. It's just useless. So I really hope
Yeah.
that, you know, I mean, the numbers hopefully will come down soon, but that's when the real work will start with in terms of long
You know,
COVID.
sometimes medicine is not all about the numbers. You know, of course, we
Mm.
want evidence-based medicine. We're looking at numbers, like, you know, someone saying, oh, it's only 100,000 patients, children who are infected, nothing so great, small numbers. But if that one number was your child, that whole
Yeah,
100,000
exactly.
wouldn't matter. So if that one person infected was you, it really doesn't matter about the 800,000 people, because it's you.
Mm.
You know, so in that sense, numbers don't make a difference, but you need to take out you need to take care of yourself. You need to community needs to take care of everybody. Kita jaga
Yes.
kita lah, basically. Kita jaga
Betul.
sendiri,
And
kita jaga kita.
well, I hope that spirit still lives up, you know, because sometimes when we are pushed to a very dire circumstances where we are, you know, people tend to just
Yes.
take care of themselves, you know. So I hope that still lives on.
Malaysia boleh
Okay.
lah, can lah. I
All
still have
right.
faith in Malaysian humanities and so many of our Malaysians out there who are doing all they can to support everybody who is, you know, putting up
Yes.
a white flag. And I think
Yeah.
that's something that is so resilient. Malaysians are resilient. We will get through this. So, but thank you
Yes.
so much, Prof. Anwar. Thank you, Anwar. You know, it's been a
Thank
while
you,
since I've actually had a
Raki.
conversation. Thank you
Yeah.
so much, and good luck
Pleasure.
and God bless. And
You too.
it was absolutely wonderful to see you tonight. Take care.
My pleasure. Take care. Good night. Bye.